Hello, my name is Wendel Naumann. I'm a GYN oncologist at Atrium Health, Wake Forest University in Charlotte, North Carolina, and I am joined by the co-director of the IGCS 360 program, Dr. Flor Backus at The Ohio State University. And we're excited to have Rachel Grisham here, who is a professor at Memorial Sloan Kettering in New York. And we're here to talk about the long-term safety of avutometinib and defactinib in recurrent low-grade serous ovarian cancer, insights from RAMP 201. And this was based on a recent presentation at the SGO annual meeting. Rachel, it's great to have you here, and would like to have you talk a little bit about the data that you presented at SGO.
Great. Thanks so much, Wendell and Flor. I'm so excited to be here today. And really, I think it's going to be an interesting discussion to talk about these data that were recently presented at SGO. So this was a long-term analysis of the safety and efficacy of avutometinib and defactinib for treatment of women with recurrent low-grade serous ovarian cancer in the ENGOT-OV60 GTG UK GOG 3052 RAMP 201 study. And what I'd like to talk to you about today is the insights from this SGO presentation, and also how are we using avutometinib and defactinib right now for our patients in clinic now that these drugs are commercially available, and how else might we be using them in the future. These are my disclosures, and I will be discussing both on-label and off-label use of avutometinib and defactinib. So as we know, low-grade serous ovarian cancer is a histologically, molecularly, and clinically distinct disease from high-grade serous ovarian cancer and accounts for less than 10% of newly diagnosed epithelial ovarian cancer cases. These tumors generally do not have HRD or BRCA mutations, but most commonly have MAP kinase alterations, and about a third of these tumors are driven by KRAS mutations. We now understand that these KRAS mutations are not only a biomarker which we can potentially target with targeted therapies, but also a prognostic indicator that our patients that have KRAS mutant disease have overall improved prognosis and outcomes versus KRAS wild-type patients. Despite this, response rates to traditional chemotherapy in the recurrent setting are generally less than 13%. More recently, with the use of single-agent MEK inhibitors, such as trametinib or binimetinib, we've seen higher response rates of 26 to 16%, but this has been limited by cumulative toxicity. Ultimately, about a third of patients treated with a single-agent MEK inhibitor for low-grade serous ovarian cancer will discontinue their treatment due to toxicity. We therefore were interested in the use of combination targeted therapy dosed with an intermittent schedule. This is to try to enhance the efficacy of the combination while decreasing toxicity by allowing our patients to have a treatment break and be able to better tolerate the treatment. Avutometinib is a first-in-class oral RAF/MEK clamp that potently inhibits MEK. And defactinib is another oral agent which helps to prevent drug resistance through multiple pathways. In the ENGOT-OV60 GOG 3052 RAMP 201 study, the combination of avutometinib with defactinib showed incredibly promising results with a response rate of 31% in the overall population and a 44% response rate in those patients who had a KRAS mutation. And ultimately, at the time of the initial analysis, only 10% of patients had discontinued treatment due to adverse events. The results of the phase 2 RAMP 201 study led to FDA accelerated approval of avutometinib and defactinib for treatment of women with KRAS mutant recurrent low-grade serous ovarian cancer in May of 2025. The purpose of this analysis that was presented at SGO this year was to look at the long-term follow-up from those patients that were treated on the RAMP 201 study. The initial analysis was based on about a year of follow-up, and this long-term analysis had about twice the follow-up. The RAMP 201 study was designed in order to answer multiple different questions, and I think that's so important when we have patients with a rare tumor. We want to be able to get as much information out of that study design as possible. So this study enrolled women with recurrent low-grade serous ovarian cancer who had received a prior platinum-based chemotherapy, but after that they could have had unlimited additional lines of therapy. They had measurable disease, and they were allowed to have received a prior MEK inhibitor before they went on treatment, because the phase 1 data showed us that even patients who had progressed on prior MEK inhibitors could respond to this combination. In parts A and B of the study, patients were randomized to treatment with avutometinib and defactinib at the standard dose versus a higher dose of avutometinib as a single agent. So this was to look for the relative contribution of each drug. Following enrollment to parts A and B of the study, it was found that those patients that were treated with the combination of avutometinib and defactinib had higher response rates but similar side effects to those patients that were treated with avutometinib alone. Therefore, the decision was made to go forward with the combination dosing. Part C of the study was an expansion phase where additional patients were enrolled at that standard dosing of avutometinib and defactinib. And then Part D was a dose optimization cohort. These patients were treated with a lower dose of avutometinib in combination with defactinib, and it was found that that dosing was suboptimal. So this long-term analysis is based on those patients who were treated with the standard dose of avutometinib and defactinib in parts A, B, and C of the RAMP 201 study. This includes 115 patients, 58 of whom had a KRAS mutation and 57 of whom were KRAS wild type. And when we talk about KRAS mutation status for this study, we're referring specifically to somatic tumor testing and not circulating tumor DNA. And the reason that we use somatic tumor testing, both for stratification and analysis of these results, is that we have found that ctDNA is not very precise for detecting KRAS mutations in patients with low-grade serous ovarian cancer. In fact, when looking at patients who enrolled to the RAMP 201 study, there was very poor concordance between circulating tumor DNA results and somatic tumor testing results for KRAS mutation status. In fact, only 44% of patients who had a documented KRAS mutation in their tumor had that detectable by ctDNA. So I think that's a good reminder for our patients with low-grade serous ovarian cancer. When we're looking to see if they have a KRAS mutation, this testing should be done on the tumor and not on the blood. For those patients that were enrolled, they had a median of 3 prior lines of therapy. About half of them had received prior bevacizumab, and about a quarter of them had received a prior MEK inhibitor before going on study. At the time of this long-term analysis, the median follow-up was 24.9 months. Overall, about 85% of patients have discontinued treatment, 79% of the patients with a KRAS mutant, and 91% of the patients who were KRAS wild type. The most common reason for treatment discontinuation was progression of disease, and ultimately only 12% of patients have discontinued treatment due to toxicity. As previously reported, the overall response rate was 31% by blinded independent central review, with a 44% response rate in those patients with a KRAS mutation and a 17% response rate in those patients who were KRAS wild type. And this long-term analysis confirms that these responses are durable. So the median duration of response for the cohort was 31.1 months. So these patients really are staying on treatment for years. And I continue to have multiple patients in my practice who were originally treated on this RAMP 201 study and now continue on treatment using commercial supply. Looking specifically at those patients who have a KRAS mutation, the median duration of treatment was 12.6 months, and it took on average 3.7 months for them to reach a response. So usually we're seeing that around our second scan. 52% of patients remained on therapy for more than a year. And then when we look at the KRAS wild type patients, we have to remember this is a poorer prognosis group. So these patients do worse with standard of care therapy and with targeted therapy, unfortunately. But we still had clinically meaningful benefit in these patients. The median duration of treatment was 7.2 months, and 30% of these patients remained on therapy for more than a year. Progression-free survival was similar to the initial analysis, with a median PFS of 19.6 months for those patients with a KRAS mutation and a median PFS of 12.7 months for those patients that were KRAS wild type. When we look at adverse events, the most common side effects that we see with this combination include nausea, diarrhea, peripheral edema, which can include the upper extremities, lower extremities, and periorbital edema, rash, which is oftentimes an acneiform rash involving the face and upper chest area, and then elevated blood CPK, which is usually asymptomatic, but should be monitored in blood during treatment with this combination. And what we see in the long-term analysis is that no new safety signals were identified, and that the toxicity that we see with this combination is generally not cumulative. Most of the toxicity that we see is really front-loaded, with most of our patients that are developing significant toxicity having that appear during the first 3 to 6 months of treatment. But for our patients that are able to remain on treatment long-term, oftentimes the treatment actually becomes more tolerable over time. Overall, 84% of patients had AEs leading to dose interruption, but only 37% of patients had AEs leading to dose reduction, showing that many of these patients were able to hold treatment and then resume at the same dose, which I think is important because for these highly effective therapies, the dose matters, and we don't want to be doing unnecessary dose reductions if not necessary, so that our patients can get the maximum benefit from the drug combination. The most common treatment-related adverse events that led to a dose reduction were elevated blood CPK or rash. And so it's really important to remember when treating patients either with a single-agent MEK inhibitor or with avutometinib and defactinib to try to use those prophylactic measures that can help prevent toxicity. So I start all of my patients that are on treatment with a single-agent MEK inhibitor or on treatment with avutometinib and defactinib. I start them on a prophylactic antibiotic for at least the first 4 months of treatment. I oftentimes continue it indefinitely. I usually use minocycline, 100 milligrams once a day, or it can also be given twice a day. You can also use doxycycline. I also encourage my patients to use a topical cortisone cream at the first signs of development of rash. I counsel them extensively before starting treatment about avoidance of excessive UV exposure and about using appropriate sun protection. And by doing these things, we can really help to prevent a lot of the toxicity that we see with these targeted agents, or at least lessen the side effects. And in terms of the other side effects patients can develop, when my patients have edema, I oftentimes have them start Lasix 3 times a week. We can also use compression stockings. And then for the GI side effects, I generally manage that similarly to how I would with chemotherapy. But at the time of this long-term analysis, ultimately, only 12% of patients have discontinued treatment due to an adverse event, showing that this combination can be quite tolerable for long-term dosage administration. So I think the main takeaways from this long-term analysis was that both patients with KRAS mutant and KRAS wild type had meaningful responses to treatment with avutometinib and defactinib, and that these responses are really durable and that patients can stay on this treatment for years, with overall 52% of patients with a KRAS mutation remaining on treatment for more than a year, and 30% of patients that were KRAS wild type remaining on treatment for more than a year. So, I think it's a really exciting time for our patients with low-grade serous ovarian cancer. We now have the option of avutometinib and defactinib commercially available in the United States for patients with recurrent KRAS mutant low-grade serous ovarian cancer. But what are the next steps for this combination? So the confirmatory phase 3 study has actually already fully accrued to its primary endpoint. So the GOG 3097 RAMP 301 study is looking at patients similarly with recurrent low-grade serous ovarian cancer who have measurable disease and have received at least 1 prior line of platinum-based chemotherapy. The patients, again, are stratified by whether they have a KRAS mutation or don't have a KRAS mutation. And then they're randomized to treatment with the standard dosing of avutometinib and defactinib versus investigators' choice of standard of care therapy, which could be pegylated liposomal doxorubicin, weekly paclitaxel chemotherapy, letrozole, or anastrozole. So patients enrolled to this study who enrolled to the investigator's choice arm did have the option for potential crossover to the investigational arm at time of progression. The primary endpoint of this study is PFS, and the results will look in a hierarchical analysis to first look at PFS for those patients who had a KRAS mutation, and then look at the overall population. So it is the hope that this confirmatory phase 3 study leads to full FDA approval of avutometinib and defactinib for our KRAS mutant patients, but also potentially FDA approval for the KRAS wild type patients, depending on the results that we see with this phase 3 study. But we always want to be thinking about moving our most effective treatments forward. We don't want to wait till we have recurrent disease to use an agent that looks like it potentially has better response rates in PFS than what we see with standard of care chemotherapy. So the Chameleon study is an IIT developed by Dr. Beryl Manning-Geist when she was with me at Sloan Kettering. And this study is now open both at Sloan Kettering and at Emory, where Dr. Manning-Geist is attending. And this is looking at the use of avutometinib and defactinib in combination with letrozole in our worst prognosis patients. So those patients with newly diagnosed low-grade serous ovarian cancer who have too extensive of disease for primary debulking and therefore require neoadjuvant therapy, or those patients with newly diagnosed low-grade serous ovarian cancer who have undergone a primary debulking and had a suboptimal debulking with measurable residual disease. So these are our patients who we all know have a really poor prognosis. Oftentimes, when we give neoadjuvant chemotherapy to these patients, they never even get to surgery. So the goal here is to really take those patients with the most aggressive disease initially and try to give them the most effective treatment so they have the best chance to get to surgery and hopefully get into remission. So this study treats these patients with the combination of avutometinib, defactinib, and letrozole. And if they have an ovary in place and are premenopausal, they also receive Lupron with that combination. And for those patients that are receiving this neoadjuvant, the goal is to get to interval debulking surgery. And for those patients that had a suboptimal debulking, we are looking at response rate. And the primary endpoint for this study is response rate. So this study is currently accruing, so we look forward to presenting results in the future, but it's been accruing very well, and we're very excited to be able to offer this option to our patients in the investigational setting. And I think it's important to remember that while these drugs are very effective in the recurrent setting, they do work best in our patients that are less heavily pretreated. So we always want to be using our most active agents first. I don't think any of us think that we should use our suboptimal treatments first and then wait until later lines of therapy to get into our most active agents. So we really see the highest response rates with avutometinib and defactinib in our patients who are receiving them in earlier lines of therapy. So I just want to make sure that we remember to think about this combination for our patients at time of first recurrence, at time of second recurrence, so they have the opportunity to receive these medications. And also just a reminder that this combination was active in our patients that had received a prior MEK inhibitor. So even a patient that had received prior trametinib or binimetinib or cobimetinib and may have discontinued that treatment due to toxicity or due to progression, I would still consider avutometinib and defactinib as an option for them. So really, I think my take-home points here is that the combination of avutometinib and defactinib has shown durable, clinically meaningful responses, both in our patients with KRAS mutant and wild-type low-grade serous ovarian cancer. Currently, the combination is FDA approved for those patients with a KRAS mutation. So we must make sure that we know if our patients with low-grade serous ovarian cancer have a KRAS mutation. And if blood testing does not show that KRAS mutation, that is not reliable. You have to do that testing on the tumor if you do not see it in the blood. The confirmatory phase 3 study will hopefully report out next year and give us more information about this combination randomized to standard of care therapy. And for our patients who are currently receiving this combination as a standard of care through commercial supply, we have to remember to give our patients the appropriate education and prophylaxis to enable them to be able to stay on treatment long term and avoid unnecessary dose reductions, because for these highly effective therapies, dose does matter. So thank you.
Thanks. Really exciting data. I think all of us who treat low-grade serous ovarian cancer are excited about this combination. So, Flora, what questions do you have for Rachel concerning these new studies and new data?
Fantastic data, very exciting. I think what a lot of us struggle in the clinic with, like, where do we put this agent? And I love the slides where you show, like, with your prior lines of therapy. So how do you sequence your regimens for low-grade serous patient that is KRAS mutated, and what do you do for the ones that are KRAS wild type? Because we have quite a few of those too.
Yeah, of course. Yeah, no, that's a great question. Thank you. So I really do think it's important that we put our most effective therapies first. So for my newly diagnosed patients, if they're a candidate for the Chameleon study, I put them on that. But of course, most of us don't have that available. So I consider my standard of care first line therapy for advanced stage low-grade serous ovarian cancer to be adjuvant chemotherapy followed by letrozole, based on the results that were recently presented at SGO by Amanda Fader. But then when our patients develop recurrent disease, for my KRAS mutant patients, I'm pretty quickly going to avutometinib and defactinib. I think that we know that those response rates to chemotherapy or to single agent endocrine therapy are quite low, generally less than 15%. And so I want to use my most active agent. And I think also because these agents are oral, we have to make sure that our patients don't miss the window of opportunity to receive targeted therapy, because once we have bowel obstructions or poor absorption because of decreased GI motility, we may not be able to benefit from these agents as well. So I am using avutometinib and defactinib second line for my patients with KRAS mutant low-grade serous ovarian cancer. It's not currently approved for our KRAS wild type patients, but based on that efficacy that's been seen with a median PFS of greater than a year in our KRAS wild type patients, I have prescribed this to some of my KRAS wild type patients also who did not have other good standard of care options, with mixed results from insurance. But I think writing appeal letters to insurance is a big part of all of our jobs now. And so I do try to get that for my patients who I think would benefit from it and don't have other options. But other things that I'm doing also for my patients with recurrent low-grade serous ovarian cancer, I'm making sure that I have all my biomarker information. And so checking my IHC for HER2 overexpression, folate receptor overexpression, PD-L1 levels. We don't have clinical data specifically for the activity of these newer ADCs and taxane immunotherapy combinations in low-grade serous ovarian cancer. I think we need as many options as we can have for these patients. So I want to make sure that I'm testing for all available biomarkers.
What do you think about, I'm sorry, what do you
ahead.
think about what do you think about the possibility of this combination replacing primary chemotherapy and endocrine therapy in low-grade serous?
Yeah, I think that there's multiple different ways that could work. I think the neoadjuvant population is a really exciting population for us to be looking at right now, because we all know these patients do so poorly with chemotherapy. And I think a randomized study in that setting could potentially show that this combination may be more active than chemotherapy in that setting. I think with the results of GY019, a lot of people were disappointed to see that letrozole was not non-inferior to chemotherapy followed by letrozole, because they have trouble telling their patients to receive chemotherapy when they know the response rates are relatively low. So I think we all are eager for more effective options for our patients in the adjuvant setting. And so I think that there are potential ways forward where we could develop these drugs both in the neoadjuvant and the adjuvant setting. We just have to get those studies open.
Great. And one more practical question, because this regimen, like you said, can have some side effects, but if you're on it, you can mitigate it. A couple questions. Do you prophylactically also give, you mentioned about for the prophylactic therapy for the rash, but how about for nausea and diarrhea? Do you give prophylactic medications for that too?
So
And how do
personally,
you
I
handle?
don't, yeah, because most of my patients don't have significant nausea and diarrhea in this combination. I would be quick to get, I think many of the side effects were grade 1. The patient certainly did have higher grade GI side effects. In my patient population, I don't prophylactically treat with daily drugs for diarrhea or nausea, but would be quick to give patients as needed medications if that occurs.
Great. And then one more question regarding like CPK values. That's such an odd one for us. Any advice on that? Because we don't really see that with other regimens other than this regimen.
Yeah, and I think the only other regimen I routinely check CPK levels for is my sarcoma, my leiomyosarcoma patients being treated with trabectedin, but otherwise it's not something I'm usually checking. And so it is a side effect of both single agent MEK inhibitors and avutometinib that it can cause CPK elevation. Now this is usually asymptomatic, but if it gets up to grade 3, then we have to hold treatment because we don't want to have that risk of rhabdomyolysis. And so I counsel my patients to stay well hydrated and to try to not pursue any new overly vigorous exercise regimens to kind of stay at the same level of exercise they're at currently when they first start the regimen. But generally, this is just something that we have to monitor when we're on treatment, the same way we monitor TSH when somebody's on immunotherapy. It's just part of the treatment. And then usually, if it does become elevated to grade 3, can be managed by just dose holding. And oftentimes, you can resume at the same dose without needing a dose reduction if you've held for CPK elevation. It depends on whether there was an event that led to it. So sometimes it's because the patient went on a hiking vacation where they were really hiking a lot, and it was a lot more muscle use than they would usually have. In that case, I wouldn't dose reduce the patient. I would hold until it had resumed to normal level and then resume the treatment.
Great.
So what about sequencing? Let's assume that 301 is positive and they get a full approval for KRAS wild type. How would you, based on the data that you have, sequence patients with KRAS wild type low-grade serous ovarian
I
cancer?
think I would do it the same way because these patients unfortunately have a worse prognosis. Our KRAS wild type patients are more oftentimes are younger patients with more aggressive disease. And so KRAS mutant patients are typically our older patients with that more slower growing disease, more the typical low-grade serous ovarian cancer that we think of. And then our wild type patients are oftentimes these patients are diagnosed at a young age, their 20s, 30s, 40s, and have overall worse responses to chemotherapy and endocrine therapy. And so, those are the patients where really I'm looking for more effective treatments and who usually are not well managed with endocrine therapy alone. And so we really need more options for those patients. So I'm really excited to have targeted therapy options for our wild type patients.
Yeah. Although I will say the PFS of a year was pretty impressive in the KRAS wild type. So, I mean, I think even though the response rate was considerably less, that was encouraging to me.
Oh yeah, for sure. I agree.
Rachel, can I ask a final question? What is your go currently before hopefully we see this approval and broaden this approval for the KRAS wild type patients also? What is your go-to regimen for those patients? Because that's always a struggle. I think
Second
in
line
many of our,
therapy.
yeah.
So some of these patients have like very aggressive, rapidly dividing disease. And so, chemotherapy works best in rapidly dividing tumors. So I certainly do use chemotherapy in my patients whose disease is growing quickly. I also like to use bevacizumab combinations, bevacizumab with chemotherapy or with oral Cytoxan. I check all of my IHC biomarkers, clinical trials, of course. And hopefully also soon we'll have more options for CDK4/6 inhibitors in combination with endocrine therapy for treatment of these patients. That's also a tough thing where we see promising data in the clinical trials, but we don't yet have an approved combination or a compendium listed combination for our patients with low-grade serous ovarian cancer. But I look forward to hopefully being able to prescribe that combination for my patients in the near future as well.
Wonderful.
Well, Rachel, thanks again for a very insightful presentation and discussion, and we really appreciate you coming on to share your experience with this exciting combination.
Thanks so much for having me.